MISMARPE or dome, what is it? Welcome to this episode of Orthodontics in Summary, where we take a look at two seemingly opposing ideas when it comes to maxillary expansion, that of surgically assisted expansion as well as that of miniscrew assisted expansion. Now these two ideas have been brought together to provide advantages that each individual modality may not be able to offer. In terms of describing what these two terminologies mean, MISMARPE stands for minimally invasive surgery miniscrew assisted rapid palatal expansion. This was established by Haas back in 2021. Dome is known as distraction osteogenesis maxillary expansion. That was Lou back in 2017. Both these ideas are relatively similar. I'm going to describe what the protocols are, both in terms of surgery as well as the expansion, and then tie that together with what we understand in terms of SARPE or surgically assisted expansion, where the real advantages of this particular approach lie, as well as comparing it to miniscrew assisted expansion. So what is the protocol for MISMARPE or dome? Well, it essentially involves having an osteotomy, but not a complete Lefort 1 osteotomy, as would be the case for conventional surgically assisted expansion. So there's an initial incision that takes place vertically, interdentally up to the periform fossa. And there's also an osteotomy that takes place laterally at the base of the zygomatic process. The key thing here is that there's no pterygomaxillary disjunction that takes place. In terms of the activation in surgery, it is as it is typically during SARPE, where there is activation to ensure the diastema opens and then subsequently closed. When it comes to looking at the surgical time, this was really interesting. And the average surgical time for this approach was 24 minutes. That's significantly shorter than the conventional Lefort 1 osteotomy, which is usually an hour and a half plus. When patients were looked at afterwards and asked what pain levels they felt, it seemed to be relatively mild on the visual analog scale. And this is put down to the lack of that pterygomaxillary disjunction, which causes significant swelling and subsequent pain to patients, avoided through this approach. In terms of the expansion protocol, it follows the osteogenesis process. In terms of having 7 days of no expansion, or the latency phase, followed by the active expansion period. There's a range of rates that seem to be subscribed to this particular modality, but anywhere between 0.25 millimeters per day to 0.5 millimeters, with some slowing down once the diastema opens itself. What are the advantages of this particular approach? Well, from a comparison to surgically assisted expansion, the osteotomy is significantly less. There are less cutting that takes place. As a direct result, there seems to be less discomfort for patients, but also it changes where this surgery can take place. Typically, SARPE will happen in a hospital setting, but due to the lack of pterygoid disjunction, actually this can happen under sedation or even local anesthetic, and not be required to be in a hospital setting. Instead, an outpatient setting is sufficient. There's also a difference in the shape of expansion which occurs, with minimally invasive surgery combined with miniscrews offering relatively parallel expansion, whereas typical SARPE or surgical assisted expansion results in V-shape expansion. That's greater anterior expansion than posterior. What about in comparison to MARPE or miniscrew assisted rapid palatal expansion? Well, we know the greatest limitations of the MARPE approach is the age of the patient. We know it's relatively predictable to gain separation in females up to the age of 30, slightly younger males up to the age of 24 at 80% success rates. However, as soon as we go above 30 across both genders, success rates drop to 20%. That is where the minimally invasive surgery combined with miniscrews has a significant advantage, with a success rate of 96%. But also the age group where this particular data was gathered from, which was Piccoli's paper from 2023, the majority of the patients were over the age of 30, increasing the range of where expansion can take place without necessitating the invasive surgical approach of SARPE. Does it make a difference as to the amount of expansion that takes place? Long and short is that it does not make a difference. We still get significant skeletal expansion using this approach, which is equivalent to that of surgically assisted expansion. And that was a publication carried out by De Silva, which showed approximately 3 millimeters of expansion across both groups. And also, interestingly enough, showed no significant difference when it came to the angulation of the molar teeth between both. So what are the indications for this approach, where there's minimally invasive surgery combined with miniscrews? Well, the first is that of failed MARPE, where we've not managed to achieve successful separation, therefore surgery can be indicated for them. For patients who are above the age of 30 or males above the age of 25, this gives us a significant increase in predictability of getting that separation. The question that's left to answer is that, is there still a need for SARPE if we have this particular approach? The data at this stage is very much limited, but I'm excited about this new concept and look forward to seeing more information about this particular topic in the form of clinical trials. A quick update for me, I'm really excited to have launched our TAD Users Conference, which is taking place later on this year in November. It's going to take place on the 21st and Saturday in London. I'm excited to be involved in organising and hosting this event and hope to see you there. As always, please do subscribe and look forward to the next episode.